Good morning, guys. David Johnson here from the Functional Movement Training Centre, City to Coast Neurosurgery and the Back Pain Centre. This morning I'm just going to talk to you about a very common complaint. In fact, the most common complaint of all of patients that come to our centre is pain, and mostly it's spine region pain, so back pain or neck pain. And I just had a consultation with a patient, and the way we talked about his pain, he said to me, was really helpful in the way he could then understand what needed to be done to help him with his pain. And it was a very simple way of explaining pain to him. And I thought it just sort of resonated with me that if someone who's had pain for the better part of 5 years benefited from that explanation, I thought, well, let's put that out there to the rest of the community that is suffering from back pain and that's watching or listening to this video. So I just started off by talking about the domains or mechanisms of pain that we understand in physiology, and I drew a matrix that looks like this, and in each of these boxes, there's 4 boxes here, I wrote up the 4 main pain processes, and they are inflammatory pain. Number 1, inflammatory pain, neuropathic pain, neuropathic pain number 2, and nociceptive pain. Okay, nociceptive pain. Hope you can see that. And the last one, the last main mechanism, is what we call central pain. Okay, so there's 4 physiological processes that we appreciate and understand that mediate the awareness or perception of pain in the human body. And we'll go through those very quickly, and this is what I did with my patient. Inflammatory pain is really your body's response to an insult or trauma, and there are many examples of inflammatory pain. For instance, sunburn. You can be out in the sun having fun, you're not really aware that there's any pain developing. For instance, if you're at the beach, you feel fantastic, but by evening you say, oh, I spent too much time in the sun, didn't have enough sun protection, now I'm feeling quite hot, and your skin will go red, and you'll feel that pain associated with that insult of the UV light. And that is your body's response to that insult of the UV light. So let's just write down there, it's like sunburn, and it can take a while for that pain to set in, for the physiological processes that mediate the inflammation to actually set in. Other examples of inflammatory pain might be, say, a sporting injury where you stretch something a little bit, you keep playing the sport, footy for instance, but it's the next day that you really feel sore in your thigh or your hip or your back. Okay, so other types of injury, so subacute injuries. Okay, and that not just restricted to sporting things, but work injuries. Often patients of mine will describe an injury at work. It might be quite trivial, a jar or a twist or a lifting event, that doesn't stop them continuing their day's work, but the next day or that evening they can't go to work because the pain is severe. All right, so that's inflammatory pain. Neuropathic pain is very simple to understand. Basically, in our in our bodies, in our spinal cord, our central nervous system and peripheral nervous system, if we irritate a nerve that carries sensory signals, and we refer to them in terms of pain as the pain fibers, the brain will interpret that as neuropathic pain. So for instance, a disc prolapse in your lumbar spine, in your cervical spine, that disc prolapse, which looks a bit like this on the camera. So there's a disc prolapse right there. Okay, that disc prolapse pushes on a nerve, okay, any one of these nerves here, and so then the patient will feel what is commonly called sciatic pain. So basically it's a nerve being compressed. Okay, so it's trauma to a nerve. All right, and then you will feel something like sciatic pain, and that's the word we use. Or if it's in the arm, you'll feel something called, we use the term brachyalgia. Okay, brachyalgia, which means painful arm. Sciatic pain is painful lower limb. Now, what about nociceptive pain, our third one? Nociceptive pain is derived from the stimulation of receptors in our body. So we have receptors in our skin, in our organs, in our joints, in our tendons, and these receptors can be activated by stimuli. And if we activate those receptors, then they will send a signal back to our brain. They send signals back to our brain. So, for instance, if you touch something hot, if you touch something sharp, you are activating receptors in the skin that will transmit a signal back to your brain, and you'll learn that that's sharp and that's hot and it's unpleasant, and therefore stop doing it, and you learn from that. And that is what we refer to as nociceptive pain. If we stop touching the sharp or hot thing, then the pain subsides for the most part. If we've created a lot of injury at the same time as activating that nociceptor, for instance, if we cut ourselves, the nociceptors are going to continue firing for a long time, and the nociceptive stimulus will not settle, so you'll continue to feel pain of the cut. And then the next day, even though those nociceptors may have stopped firing, you'll be starting to experience pain that's being driven by a different process, which is the inflammation associated with the activation of nociceptors. So you can now start to see how a combination of these types of mechanisms can be in place at the same time. Now the last one, central pain, is derived from the central nervous system itself, okay? So when we say that, we really are referring to the brain stem, and the spinal cord. Okay, we're talking about the neurophysiology of the central nervous system itself, and what promotes the development of centralized pain is poorly managed 1, 2, and 3. So this is 1, this is 2, and this is 3, okay, and this is 4. So if we manage inflammatory pain badly, if we manage neuropathic pain badly, if we manage nociceptive pain badly, the central nervous system starts to go, hang on, why have you not sorted out my inflammatory driven pain? Why have you not relieved the pressure on my nerve root? Why are you continuing to stimulate these nociceptors? And if that happens for weeks, months, or years, the central nervous system develops some unusual habits. We can call them habits, but we're talking about neurophysiological changes in the central nervous system that almost become autonomous in that they are maladapting to the acceptance that these pain symptoms are not effectively managed, okay? And that becomes a very significant problem for patients because it's almost like they are developing these tangles of neural connections within their brain that shouldn't be there, okay? We can call them neurotangles if you want, neurophysiological tangles that shouldn't be there, okay? The communication between the nerves in the central nervous system start to get corrupted. And it's only because these things are not managed effectively. And that's when people start to develop chronicity, okay, chronic pain, as opposed to these type of things, which are really a part of acute pain. So the one thing that drives chronic pain is poorly managed acute pain. And that's why it's very important when you have your first episode of back pain or your first episode of a disc prolapse that you manage those episodes of pain effectively so that you don't start to fall into this, you don't start to accumulate this type of pain physiology, number 4, central pain. And what was really relevant in my patient understanding and what made him appreciate their consultation so much was he had an obvious disc prolapse that hadn't been addressed for a long time, and it was temporarily addressed by me arranging for him to have a nerve root block. And when that nerve root block was actioned, a lot of his neuropathic pain settled down. So, a lot of his overall pain symptoms settled down. He rated it a pain improvement of more than 50%. So when we temporised his pain, he got 50% reduction in his pain. Now, what about the other 50% of pain that he rated that he was still experiencing? Well, that we can arbitrarily say that maybe there was still some inflammatory pain of, say, 20%. Maybe there was still 20% coming from inflammatory driven pain. There could have been another 10% coming from ongoing stimulation of his nociceptors, and another 20% continuing as a result of centralized processes. And why this is so relevant is that I had to say to him, when we relieve the pressure on the nerve, okay, I can do that in 1 hour with an operation. I can remove the compression on the nerve, and so we can effectively establish immediately after surgery a 50% reduction in his pain. But a week later, after surgery, the patient is still going to experience this persisting central pain element of 20%. There may be a slight reduction in nociceptive stimulation of 10% and some inflammatory stimulation of 20%. So it's very, very important to understand that the surgery is really only fixing up what a structural repair can fix up. And in his case, around about a 50% reduction. The ongoing pain management doesn't stop there because most people want 100% recovery, okay? That's sensible, isn't it? We want to be 100% better. And even though patients might be happy with this 50% reduction, we still strive to unwind this 20%, this 10%, and this 20% of these other mediators of pain. And the only way that we can surely remove the inflammatory pain, the nociceptive pain, and the central pain is to ensure the functional rehabilitation. We've done the structural rehabilitation with the surgery. That's easy, but the functional elements of a healthy working system need to be focused on just as much, and that usually is the hard bit of managing pain. The easy bit is the structural fix, the hard bit is the functional fix. And the health of every system is very much dependent on the interplay between structure and function. So the structural elements are sometimes required to be, we sometimes have to repair the structural elements with surgery. We always have to repair the functional deficits that are usually the driving factor that created the structural elements in the first place. So surgery is just one part of the equation to repair structure, and the functional rehabilitation is the major component of getting on top of chronic pain. And that's exactly what we focus our attention on here at the Functional Movement Training Centre and the Back Pain Centre. And my surgical practice, City to Coast Neurosurgery, just has this very small role to play, really, in terms of repairing structural deficits that impede the acquisition of functional movement proficiency. The only time I need to operate on people is if the structural breakdown is so far advanced that it interferes with the ability to gain the functional movement proficiency. Okay. If the structural breakdown is, it's not too bad, it's not fantastic, it's not perfect, but if we can still implement a default movement pattern of functional proficiency, of movement proficiency, then what can actually happen is that you can actually start to automatically repair these things, these drivers of pain. You can start to repair those things spontaneously, allowing your body to do the work, not the surgery. Okay, so in fact, the vast majority of patients that we see, probably about 9 out of 10 patients, don't need any surgery at all. And if we engage in functional movement therapy, these elements, these four elements that are driving pain symptoms, just steadily improve over time. Okay. So I hope that makes sense, and I know it's a slightly long video, but it's a little bit complicated there, and the subtleties of understanding it are really important. Once you understand those subtleties, it's really quite simple and fundamental. I'm a bit of a fundamental Nazi. They're fundamental to recovering from your chronic pain. Okay, until next time, thanks very much for watching. Bye-bye now.